Hello, my name is Tyler Ryan, and I'm a fourth year medical student at Boston University. Thank you for joining me for this clinical vignette on the use of afterload reducing agents in right heart catheterization. HFrEF and HFpEF represent physiologically distinct types of heart failure that require separate treatment approaches. Choosing a treatment can be especially challenging in patients with ejection fractions somewhere in the middle, between 40 and 50%, as we'll see in this case. So this is a 72-year-old woman with a history of HFrEF, hypertension, group 2 pulmonary hypertension, and CKD stage 4 who presented to the ED from Palm Clinic for 1 month of shortness of breath. She was volume overloaded on exam with pulmonary vascular congestion on chest x-ray. Her creatinine, BUN, and BNP were elevated, and she was presumed to have acute decompensated heart failure before being started on IV Lasix. She also underwent a TTE that showed an EF of 47%, normal left ventricular cavity size, dilated left atrium, and mildly increased wall thickness, consistent with a HFpEF phenotype. However, despite diuresis, her creatinine and BUN steadily rose over the next 5 days. She underwent a right heart cath on hospital day 6 that showed high systemic vascular resistance and reduced cardiac index, more consistent with a HFrEF physiology. So we have a right heart cath suggesting HFrEF and a TTE suggesting HFpEF. So this discrepancy prompted us to pursue pharmacological interventions to better characterize her heart failure. And this was really based on a paper out of the Journal of the American College of Cardiology that characterized how hemodynamics in HFrEF and HFpEF respond to afterload reducing agents such as nitroprusside. So we figured we'd give this a go, starting with an oral afterload reducing agent, hydralazine. Our hypothesis was that if the right heart cath was correct, and this was a HFrEF picture, then her cardiac output and renal perfusion should improve with hydral. However, hydral increased her creatinine and BUN and failed to improve kidney perfusion after 2 days, so we stopped the hydral. But we still didn't have an answer to her question, so we brought her into the cath lab and performed a right heart cath with nitroprusside infusion to determine how her cardiac output would respond to afterload reduction in real time. So nitroprusside doses of 0, 0.5, and 1 micrograms ended up decreasing cardiac output from 4.4 liters per minute to 3.9 to 3. And you can see that on the middle graph here. Now, in addition, we also observed a pretty substantial drop in blood pressure in response to nitroprusside, as we see on the graph to the right here. So, in the presence of nitroprusside, blood pressure dropped from about 150s over 90s down to about 70s over 40s. And when we compared our results to the physiology papers that we read, this seemed pretty consistent with a HFpEF physiology. So, afterload reducing agents such as hydralazine and ACE inhibitors were avoided for the remainder of the admission, and patient was also allowed to remain at more elevated blood pressures. They were transitioned to oral torsemide upon reaching euvolemia, and renal function stabilized before the patient was discharged home. So distinguishing between HFpEF and HFrEF can be a pretty challenging branch point in therapeutic decision making. But this case suggests that using afterload reducing agents during right heart cath may be a useful tool in trying to make treatment decisions in patients with intermediate range ejection fractions. Thank you very much.